Thank you very much to Mike for joining us from Nashville, Tennessee.
Yep.
And he's got a very long CV and has. Sorry about the echo here. Dr. Habig is not here to sort it. So I will let Mike introduce himself and teach us what he's learned from lessons on the battlefield.
Well, thank you so much. Thank you guys for having me. When Nat asked if I'd be interested, of course I jumped at the opportunity. I was actually thinking of everyone down there the other day because right now, actually, I am on a tour of various flight programs in the country, taking a look at what they do and how they operate to try and improve our retrieval service. So, but it was absolutely thrilled to be here giving this talk to you. This is sort of a new take on a talk that I've given in the past called Resuscitations Learned from the Battlefield. So for those of you who don't know me by way of background, my name is Mike Lauria. I started in the fire service doing EMS work and whatnot back in like 2002. I enlisted in the military in 2005, and I was a pararescueman in the Air Force. So my job was to provide combat search and rescue capability to various special operations organizations, as well as direct medical support for those guys on the ground. When I got out, I started doing more civilian retrieval medicine. So I went to work for the Dartmouth-Hitchcock Medical Center, and as evidence that I had hit my head way too many times and sustained multiple TBIs when I was in the military, I decided to go back to medical school. And it's pretty much worked out, and been a lot of fun along the way. And did my residency down at the University of New Mexico in Albuquerque, New Mexico, and now am in fellowship there focusing on critical care transport and retrieval medicine, which has been phenomenal. Lots of fun spending this year just focusing on that stuff. I have no disclosures. No one's willing to. The hospital generally tries to pay me as little as humanly possible, and no one else is willing to give me money for anything. So, but if anybody knows of anybody looking for a sponsor or something, I'll shamelessly plug just about anything these days. This talk really stemmed from this question that I asked. We were out at a bar one night. It said a friend of mine said, "What did you learn from 6 years of war?" And the answer was, it's kind of a hard question to answer, especially right off the bat. It's kind of like, what did you learn in medical school? Well, lots of stuff. But in terms of thinking about the key lessons and whatnot, I wasn't really sure. And over time, when I started to really think about it, I started to process things like, well, maybe it was, resilience and basically the ability to deal with abject suffering for long periods of time and overcome very difficult circumstances. And that was kind of true, but really didn't get at what I felt like the heart and soul of some of the lessons that I learned was. It was certainly, doing a lot of the technical stuff, so like parachuting and diving and all that fun stuff. That was kind of unique, but again, I don't think really it encapsulated a lot of the real lessons that I had learned, especially, again, as they pertain to medicine and resus. But even when I thought about it, I was like, well, from the medicine and resus perspective, a lot of the stuff that we did was pretty straightforward trauma care. It wasn't anything particularly crazy or particularly different, actually, from a lot of the stuff that we did in the civilian world. It was different in terms of how we applied a lot of these concepts, and the situations were a little bit different, but a lot of the medicine itself was the same. So when I really stopped, and this was several years ago, I started to really think about it. What I realized is that the lessons, especially as they pertained to resus and a lot of the stuff I was doing in residency and whatnot, were slightly different. In particular, a lot of it was the way I processed things, the way I thought about things, the cognitive ability to think through relatively complex situations, but also other abilities to sort of deal with very high stress or complex situations. And in particular, when I thought about it, being able to wade through the million shades of gray that are involved in some of these complex resuscitations, retrievals, or even stuff in the emergency department. Because a lot of times I think we kind of try and divide things into A or B. We try and make things very black and white. We have protocols, we have guidelines, but I think some of the art, where the art actually meets the science of resuscitation, is a lot of these very challenging situations that are not so straightforward. And I really thought that was, in fact, one of those things that was underappreciated and not so flashy, and you're not going to see in a National Geographic video about pararescue. But it really was, I think, the essence of what you learn, probably one of the most important things you learn in these very sort of dangerous, high-stress situations where there aren't clear answers, and you're making very important sort of life or death decisions. It kind of came to me several months later after realizing this, when I was so I'm a liberal arts nerd by preparation in undergraduate university, and so from time to time I'll pick up one of the classics and read it. And this was, in fact, when I was reading Nicomachean Ethics by Aristotle. And for the most part, it deals with a lot of different aspects of the human condition: temperance, prudence, justice. But I think one of the most interesting things is in I forget what chapter it is, but at one point Aristotle goes on and talks about these virtues of moderation, which really sort of rung true with me, because I think a lot of times, again, we kind of try and make things black and white. We divide things into it's either one or the other, and that's not so much the case. In fact, for an example, he talked about the vice or the vice of deficiency being cowardice, the vice of excess being foolhardiness, but the virtue of moderation in that circumstance being courage. In understanding where on that scale between cowardice and foolhardiness courage would fall. And that, again, sort of rung true with me. And I was thinking about it. A lot of the ability to weed through these situations, to think through things, was a balancing act. Thinking through or trying to piece out through these 1,000 shades of gray in these complex situations, a lot of the time is a fine balancing act, and finding an equilibrium that maybe not necessarily be 50-50 in terms of how it balances, but it did. And it boiled down to me to about 5 things. So I'll talk about 5 virtues of moderation, if you will, that I found or thought about in Resus that really, I think, my experience brought to light. And perhaps more importantly, sort of when I thought about the actions that I would take to deal with these situations. So these are the 5 virtues of moderation, if you will, that I took away from the special operations world that I really think are things that are important to me every day in both the ED critical care unit, our resus unit, and in the field. And so being calm but ready, thoughtful but decisive, careful but quick, confident but humble, strong but compassionate. So first, calm but ready. This one shouldn't come as too much of a surprise, and I'm sure a lot of you have heard me beat this horse to death about performance-enhancing psychological skills and the very nature of how stress in acute situations really affects the way our brains work on a electrical level, on a chemical level. It is fundamentally different the way our brains work when we're stressed out. The perceptive abilities of your brain completely change. We demonstrate auditory exclusion, we demonstrate cognitive perseveration, increased selectivity, or tunnel vision, as we call it colloquially. So all of these things, or stress, changes the way our brains perceive things, the way they work, the way they're able to pull things out of long-term memory. It affects far transfer, the ability to pull information out of the back of your brain and apply it to novel situations, and the list goes on and on and on. And although this is a gross oversimplification from what many of my human factors colleagues and human factors engineering colleagues would suggest, I think it is sufficient to just get the point across that this optimal level of performance begins to taper off at some point, but perhaps more importantly, that optimal level can be extended. And I think there's a lot of ways to do that. And I know many of you heard me go on and talk about this, but in essence, what it comes down to me is employing performance-enhancing psychological skills, or pre-hospital non-technical skills, getting your pants on, if you would, as Cliff likes to say. So I think those are actually very important and very helpful if you apply them correctly. And of course, again, I believe it was Cliff who actually gave me the Mr. T idea, but the breathe, talk, see, and focus were those key sort of psychological skills. So employing performance-enhancing breathing or box breathing, depending upon how you call it, positive self-talk, using mental practice, and also using trigger words to actually transition from sort of a preparatory phase of getting things ready to actually executing individual skills. And I still use this. I mean, when we go to land at scene flights on the highway or the motorway, and we are coming in for a landing and we're on short final, I'll do exactly that. I'll begin taking several deep breaths. I'll actually have like a little positive self-talk thing that I give to myself that's motivational. I'll use instructional stuff actually in the back of the ambulance when we're getting ready to do skills, but just showing up on scene, it'll be relatively motivational internal speech. And then thinking about, based upon what the call is, key actions that I may have to do, and mentally rehearsing those relatively quickly, even before we land on the scene. And then as soon as the aircraft is down, and the pilot shuts down, I actually use the word focus. I use it before executing individual skills too. But as soon as I say focus, I unbelt myself. So I release the latch on the seatbelt, and then it's go time. Being thoughtful but decisive. This one I think is particularly interesting because we talk a lot, especially we would talk a lot, and we do actually continue to in the military. We talk about strategy, so we use this little sand table to do to what we call dirt dive, various operations, and we did it even in the special operations community. Yes, we do a lot of computer briefing and we look at imagery and all those other things, but often it's very simple, especially if it's on the spot, like planning out like a technical rescue of someone who fell down a well, or trying to, in a tactical situation, actually extricate people from a building where someone may have clacked off an explosive and the building came down on them. A lot of the time what we're left with is this. And that planning are essentially like higher level functions, or employ higher executive function to very carefully think through and compare the various options in your head, and then you sort of pick amongst either yourself or amongst the team the very best option. Other times, things unravel so quickly in these various situations that you have to do what we call flying ahead of the plane. You are essentially more reactive. You're sort of going with like your gut instinct. And this is the sort of System 1 and System 2 type thinking that was made very famous by the illustrious David Kahneman, who I do somewhat disagree with, in the sense that when we talk about these things as being binary, that you're either in System 1 or System 2, I think that's really a false dichotomy. You can be essentially anywhere within that spectrum when you're making individual decisions. So that, I think, is evidenced by the fact that in the most extreme situations, we have this saying called getting off the X. When things are unraveling incredibly quickly, or there's an immediate, clear and present danger to the team, we just say get off the X. Don't think about anything else. Just get out of the way, get out of here. This is too dangerous. Get to cover or whatever. So that would be like the most extreme example of this. So it's this balance, in my opinion, between intuitive and analytical decision making, and not only a balance, but in fact often a blend of the two. And what's perhaps most interesting, when a lot of people in thinking about these cognitive processes don't necessarily tell you, is that actually the two most ardent advocates for both of these types of thinking. A gentleman by the name of Gary Klein, who pioneered the idea of recognition prime decision making, was probably the biggest advocate of the abilities of intuitive decision making. Whereas if you read Kahneman's book and a lot of his research in behavioral economics, talked about analytical decision making and how important that actually was. What's really cool, and people don't realize, is that these guys actually came together, and these two advocates co-published a paper basically outlining when each form of decision making was good. They kind of got together and they're like, well, both intuitive and analytical decision making are very important, and when they both actually work well. And in their paper, they outlined certain circumstances. So they said that when you have observable characteristics with quantifiable changes, so if you can watch someone's blood pressure go up and down, watch their heart rate go up and down, and you can give them medications, you can give them adrenaline, you can transfuse blood, you can do things that demonstrate changes to the blood pressure and the heart rate, those situations are actually conducive to recognition prime decision making and being more intuitive, because you're recognizing those patterns. Your mind begins to pin different numbers and vital signs to what's going on with the patient, and perturbing the system with confidence. That sort of goes hand in hand with that quantifiable change and that example I gave of administering some intervention. The variables reliably predict the outcomes. So if you've ever had a trauma patient and you've watched their end titles start to trickle down and they Brady down and then they go into cardiac arrest, when you're analyzing various variables and as they change, they reliably predict a particularly good or bad outcome, that's actually pretty good for setting you up for this recognition prime decision making. And in general, what they came up with was natural systems, i.e. biological systems, or are actually much more conducive to this than socially produced systems. When you're trying to think about like counter nuclear proliferation strategies and what someone else is going to do based upon thinking about what you're thinking that they're going to do, and back and forth, that sort of chess game, that does not work very well with recognition prime decision making. Those socially produced circumstances, another good circumstance would be like gambling, right? Does not work very well with recognition primed or intuitive decision making. But the interesting thing about this was, I think that medicine sometimes does, because it does demonstrate a lot of these characteristics, especially in sort of like the extremes of resuscitation, if you will. But also, there are times where you really got to sit down and think and analyze things. So I think there is a role for recognition prime decision making. You can absolutely do it, but that is balanced and moderated by times when you really have to perform careful analysis, when all the facts are being added up, when there's cognitive dissonance, when things don't seem to make sense, when people aren't responding as normal to your interventions. That can be not only frustrating, but those are times when you really got to step back and carefully analyze the situation and think about what you're missing, or what you're not doing correctly, or what's going on. And so the action I take is, what I say is, I trust my gut to recognize, but I use my brain to synthesize. So if I, for example, have a patient that rolls in and they look sick, and then you've seen sick before, you get pretty good at recognizing, oh, this is not going to be good. We need to move fast. We need to figure out what's going on. We need to intervene. On the other hand, when things are not matching up, or the patient looks pretty sick, but you can't figure out what's going on, or in fact, they look quite well, but there's other concerning features that may come up in diagnostic studies or wherever, you really have to stop and think. Or when you haven't seen that pattern before, when you have not seen a particular pathology or worked with a particular group of people, or don't do it regularly, sometimes that will require that careful analysis. Likewise, for various skills execution, it's not just about thinking and sort of intuitive versus analytical decision making in the moment. In fact, you can actually do them and separate them in time and space. So if you think very carefully about how you're going to perform a procedure, if you train yourself very particularly, if you're very carefully in considering the equipment and the setup and all these other things, then in fact, when it comes time to actually make that decision, you can act very intuitively. When it's time to perform the skill, you can act without overanalyzing the situation or the procedure itself.
Sorry, mate. Sorry, mate. Just sorry. Whoever's making a cup of tea in the background, could they mute themselves, please?
Hopefully that's it. Or make us some tea too. That'd be nice.
Cheers. Thanks, mate.
No problem. Careful but quick. So I will never forget one of the days that we were at the range, and one of the senior members of the team, oh man, that tea's not serving whoever it is pretty well, huh? So they're coughing in the background too. So we were at the range and we were shooting, and one of the senior members of the team goes to one of the junior members of the team who wasn't doing so hot when it came to shooting. He said, hey, slow is smooth and smooth is fast, and love to pull out that pithy little saying that many attribute to people in the military, which is not necessarily the case. And another member of the team, an even more senior member of the team, came just screaming across the firing line, and he goes, that is the dumbest shit I have ever heard. Slow is just fucking slow. Smooth is fast. And he made a point, and I think that point was well taken by everybody, albeit very entertaining, that really what we're trying to get across to people is that we don't want you to rush through them. You don't want you to blaze through a particular skill or do something too quickly that you start to screw up, or you start to make mistakes, or you start to commit errors or whatnot. What we're really going for is smooth, right? What we're really trying to do is be smooth to the point that you are careful and thorough, but not missing anything or screwing things up. And what we're getting at there is a concept that we actually define and call in the military economy of motion, right? So you're not, you get out your airway kit and you're setting up your dump so that you can perform an RSI. You're not like throwing stuff all over the place and dumping things where they're not supposed to go, or accidentally, pulling the dump kit away, or pulling or moving the dump kit and then everything goes flying. But you're setting it up so it's very smooth, so that if you can't perform orotracheal intubation, you can very quickly move to your backup airways. Or if you're in a can't intubate, can't oxygenate, can't ventilate scenario that that you need to perform a surgical cryocatheterotomy, you can quickly move to that and just sort of flow through, if you will, that airway algorithm. And that was, I think, profound and sort of an important realization. And when you sort of get into it and talk to a lot of guys that do, for example, competition shooting, or some of the best tactical shooters in the world, they'll tell you that the way to get fast is not a particular mystery. They just do the basics so well and so learn the foundational skills so thoroughly that pulling the trigger on the gun is like breathing. It's just so smooth and so natural, and an extension of your very person, an extension of your body. And that, I think, is very important to me anyway, and sort of informed and allowed me to take the action of how I completely retrained my equipment setup and the psychomotor steps of various critical resuscitation procedures, so that I could be careful, but in fact very quick. And that included, I basically started out with any skill that required a scalpel, and started to look at those individual skills, for example, finger thoracostomy, and just like I was drawing a pistol or using any other weapon system, dividing it out into the critical steps that can go very fast. So macroscopic steps like moving the patient's arm, cleaning them off, or throwing some chloroprep on there, identifying the landmarks a little bit slower and more careful, so that when I actually go to make the cut, I know that I'm in the right place. Doing the incision through the skin, the blunt dissection through the skin, can be actually very quick, but always pausing when you get to the chest when you actually punch into the chest with the hemostats or with the long penes to open up and make that or execute the final step there, getting into the chest. When you break it down into those fundamental steps of what you can do really quickly, what you actually need to be careful and thoughtful about, that also informed how I set up my cricothyrotomy kit, or excuse me, not the cricothyrotomy kit, the finger thoracostomy kit, so that as I move, as soon as I open it up and lay it out in front of me, I'm moving from right to left very smoothly. So even if all the lights went out, it was the middle of the night, I know what tool is in what particular position. And then timing it so that you see exactly how fast you're getting, how long it takes you to do it, how changing the equipment around can actually be simple interventions that allow you to move much quicker and shaving seconds off. Confident but humble. This one was very, very interesting to me when I started to think about it. And actually, so my boss when I was in Iraq was Admiral McQuaven, and this man, not only in what he's written and putting out in the popular literature, and you may have heard some of his YouTube videos, but in real life was a phenomenal leader, the kind of person that I would follow down the mouth of a cannon without thinking twice. He was really quite a phenomenal leader. And one of the things he said to us, because the tendency was to consider your enemy to be dumb, undereducated, incapable, incompetent brutes, and use some very derogatory terms to talk about them. But he always made it very clear that you should never underestimate them, that they were not, in fact, stupid, and being overconfident and not demonstrating any humility in your ability or the situation or the complexity of the situation was going to get you killed. And he was always very, very clear about that. And so I took that to heart. And although I think there is some, that this is not a perfect redemonstration of actually the relationship between confidence and experience, when Dunning and Kruger published this on the likelihood of people to overestimate their abilities, while it appears in popular literature and certainly in the foam world, it is, I think, somewhat demonstrative of how we perceive our ability to deal with things. And although it might not be 100% accurate, understanding this effect, I think, is in fact important, or at least the effect as they published it in the study. And thinking about this in a slightly different way, such that to be confident, the difference between being confident and cocky, the way it was explained to me was being, or the way I like to think about it, was essentially being aware of the potential risks, dangers, pitfalls, and other potential options in a situation, and having the guts to move forward with that decision or that particular intervention. And so I think we need to be confident, especially in the situation of resuscitation, for a number of reasons. One, actually, confidence is linked, even if that confidence is just fake it until you make it, even if that confidence is somewhat false, as it turns out, your confidence is directly related to performance, and lack of confidence is directly related to an increase in potential errors or mistakes in whatever you're trying to do. So I think we need to learn from our failures, but we need to also be confident and take risks when appropriate. When you think something needs to happen, stand and be confident to drive the situation forward and help out someone, especially in an active resuscitation. On that note, we also need to have a modicum of humility and understand that we're going to fail sometimes. We're going to make mistakes. To be able to say, even intra-resuscitation, I don't know, I'm not sure what's going on here, and I can't figure out why, I think is important. That balance is important. And so the action I take is, especially intra-resuscitation now, is I verbalize if I don't know something, state why, and ask for help. And that is probably the biggest thing intra-resuscitation for me. And I actually learned this when I was at shock trauma. One of the surgeon-in-chief, actually, one of the smartest trauma resuscitationists I've ever met, or interacted with Dr. Scalea would stop, and he would ask sometimes in these complex situations. He'd ask the anesthesiologist, he'd ask the nursing staff and the technician, what am I missing? What is going on here? And from that, I try to basically do that same thing, especially in the field, bouncing it off my nursing partner or paramedic partner. They're brilliant. They're fantastic. They are certainly good at recognizing sick and not sick and executing the resuscitation skills that are within our scope very well, and often bring things to light that I either missed because I was too stressed out, that were told to me but I didn't hear them, or help me put the pieces of the puzzle together. And I think that confidence in moving forward and doing what you need to do, but humility to ask for help and sort of admit that you don't necessarily have the whole picture is really important, I think. The last is strong but compassionate. I'll never forget, we responded to a Humvee that had been hit by, actually multiple Humvees that had been hit by IEDs. We took care of one. The other aircraft and the rescuers on it took care of the other. And I'll never forget this poor kid who was actually in the back of the Humvee, who I swear to God looked almost exactly like this, just blood dripping down his face from minor lacerations, but certainly nothing life-threatening, was still totally with it. And we had multiple casualties that were very critically injured. One was, in fact, peri-arrest. And the 1,000-yard stare on this poor kid's eyes was like, wow, it haunts me to this day. But the situation was such that without his help moving the patient and helping us extricate his friends and helping us initiate life-saving interventions, without his help, there were just not enough of us to work fast enough. We're talking about a couple medics for multiple, I think there was 5 or 6 critically injured casualties, and we had to enlist his help. And the way we did it was basically talk to him straightforward, like, I know I can't imagine how awful this is and what you're going through, but right now I need your help. You have control of this situation. You can help us save your friends' lives, and I need you to do that. I don't have the hands otherwise to do it, so you can actually step in, and I really need you to help me right now. And the kid actually rallied, which was pretty impressive. And again, is like an 18-year-old kid from the middle of nowhere in the United States. I'd not seen anything before, and then he comes to Iraq and sees this stuff, which was awful. That ability was pretty good, but the action step that I started to take was, or think about at least, was complete the mission and then heal the wounds. You have to get it done first. In the middle of what's going on is not a place to break down when other people's lives are on the line, but it's pretty rough. So getting in there and taking care of business, even if it is a really bad resuscitation or it's a little kid or something that's really, really disturbing, and then afterward, taking a break and thinking about it. So we actually talked to that kid after that mission in Iraq. Talked to him about what was going on, and we not only that, but when we brought him and everybody else back to the forward operating base, the surgical hospital in Balad, we contacted his senior enlisted officer, his sergeant. I told him what had happened, who was not out on that mission, and be like, you need to help this kid out. He's probably going to need some resources. He is probably going to need some significant help. Sadly, I never figured out what actually happened to that poor kid or how he ended up, but I use it as sort of a model for making sure that we provide that safety net for people and being very compassionate, especially in the aftermath. And if things went well, supporting them. I think part of that compassion is recognizing that despite a very awful situation, that they actually did quite well. So, calm but ready, thoughtful but decisive, careful but quick, confident but humble, strong but compassionate. I think these are lessons that I think have helped me to grow significantly, not just in my resuscitation practice, but in life in general, understanding that everything is in moderation, including moderation sometimes, but in general, it lies somewhere on that spectrum between extremes. I think that did make me a better combat medic. I think it makes me a better retrievalist and resuscitationist now, and hopefully it'll make me better in the future. And I certainly think it makes me a better neighbor, community member, and husband, in fact. So these, I think, are not just virtues of resuscitation. They are, in fact, virtues of our very human condition. And being in an awful, awful situation like a war really brings those to light in sort of a bad way, but I think it really brings those things to light, and it's changed me significantly, I would say. So I think that the biggest change, though, has been in thinking through these things and incorporating them into my retrieval and resuscitation practice, and hopefully the concept, when you think about it, can help you guys out as well. So thank you so much, and I'll return my big ugly mug to the screen now, and I'm happy to take questions or discuss this with you guys. Let's see.
Thank you very much, Mike. That was an awesome presentation, and lots to think about there. We've got quite a few people online who can ask questions or post onto our WhatsApp group, and we can put them to you. And any questions from in the room? So I was just looking at you and sort of linking into a talk we heard earlier on today about human factors. You talked about type 1 and type 2 thinking, and you talked about when you didn't know what was going on and taking time to process those. What do you do when you have lost all of your bandwidth? So you're completely maxed out. Do you have ways of recognizing you're in that stage? And how do you bring yourself back from there?
100%. So first of all, I know that the early symptom for me is actually the auditory exclusion. An early red flag is if I have my partner or someone else in the EDRU and I say something like, can someone show me that blood gas? Or what was that blood gas? And they're like, we just showed you. Like, we showed you. That was what I handed you before. Or can someone give me the EKG? And they're like, we just gave it to you. You put it back down over there. And you're like, oh, so you did mention that to me. And especially if they tell me that I acknowledged it and then completely forgot about it, that means I wasn't really processing it. So that's like an early sign for me. As things progress and potentially get worse, I think the thing I recognized in myself is as things are not going well, I start to get really frustrated. And that frustration is another, when I start to feel that's another warning sign that it's actually getting worse. How do I deal with that? When I know my bandwidth is completely maxed and I start to demonstrate those signs and symptoms, I think there's only a couple things you can do. You can try and offload some of that bandwidth, which I know people talk about on a regular basis. It is actually, I think, the more that I really think about it, is easier said than done, but offloading something and just stepping out of the room. So we've definitely had cardiac arrests at outside hospitals where once things get all set up, we'll put in a supraglottic airway, we'll get them on a mechanical CPR device, we'll be doing everything, and then the whole situation just doesn't add up. And people are throwing information at me or handing me blood gases, or the outside physician is coming in and wanting to talk to me, and it's hard to do those things at once. And more than once, I've just talked to my nurse partner or paramedic partner and be like, do you have this? Can you manage all of these guys and continue appropriate resuscitation? I'm going to step out for a second and just think about this. Take a deep breath, talk to the physician or nurse who had the patient to begin with, and try and reset that bandwidth so it's focused on analyzing the history of what's going on, not making dynamic decisions about what's going on in the room, but just focusing on that history of what happened, how things progressed, looking at like any labs they may be able to hand me and put the story together if we're able to get to the bottom of if they're was in fact anything reversible. I think partners and teammates, and one of the reasons I love retrieval so much is that you have essentially someone else who really understands the logistics and the operational complexity of the situation and is really good at it, or at least good at managing it. And therefore, I lean very heavily on my nurse partners and paramedic partners to essentially split that load sometimes, especially if there are multiple discrete tasks that need to get done, in addition to like complex cognitive stuff where you're really having to use all of that bandwidth for thinking through situations. Does that answer the question?
Yeah, perfect. Thank you very much. A message from the WhatsApp group from Brian Burns. Hey Mick, brilliant talk. What are the lessons you've learned so far on your trip around the US? The good, the bad, and the ugly.
Oh, yeah. So I've learned that our retrieval system in New Mexico has some areas for improvement. Let's just say that. I think from a lot of the lessons we've actually learned are definitely not clinical, and they're about systems improvements that we need to do. In particular, quantitative and data-driven quality assurance and improvement, which I'll admit, and I'm sort of embarrassed to admit, despite the fact that I talk about that stuff in the hospital and out of the hospital quite a bit. We're not very good at. We're not doing a very good job. The two programs that we've just visited recently do a much better job at translating what actually happens, collecting that data and using it to identify holes in their system, things that can be done better, and then translating that into viable improvements. And that, I think, is probably number one. Other things are perhaps a little bit more germane to our system here in the United States. So one of the things that we're experiencing, and I imagine to a certain extent you all are experiencing too in the hospital, is we're losing a lot of paramedics and nurses. And how do we deal with that when we can't replace them very quickly in the retrieval environment? They always want to push us to orient people faster and get it done quicker, but I don't think that's really a viable solution for a lot of our nurses and paramedics to generate the quality of practice in the pre-hospital environment. So one of the things that actually we realized was, and one of these systems does quite well, is they actually hire people as part-time first. They make them go through all the training, do everything, while they're actually working another job. So in their spare time, weekends, and other time, working very hard. And they do it because they're very motivated to get into the retrieval environment. And then when something comes up, something opens up, they're already integrated into the team. They know what's going on. They know the protocols. They've done the job before. And then the spin-up time to get that person from a part-time employee to a full-time, ready-to-go employee is a little bit shorter. And it might be a viable option for some of our systems in the United States. So those are probably the two biggest lessons learned. I would say number three is not too surprising for you guys, but is somewhat novel here in the United States, is actually the Vanderbilt transport program they work with today uses a clinician in their retrieval center. Basically, they call it their patient flow center, but it's how they move patients around this region. And I think that is, again, relatively novel in the United States. I think it follows the model somewhat of what you all are doing and what other European colleagues might be doing. And that is giving us a United States model for why we should perhaps be doing this in New Mexico. Those are the top three.
Cool, thank you very much. I think there's one more question just coming through. I'll give that time to pop through. Just going back to the clinical side, something that was going in my mind in these situations is you talked a lot about what was going on in your mind and how you managed yourself. In these big, difficult decisions, how do you bring the team along with you to achieve those goals?
So, awesome question. I think the first question I ask myself is this person on board? Like, are they with it cognitively and able to receive directed information about where we need to go and have like a discussion about or be able to essentially split the bandwidth and be able to have a discussion about what we need to do? If the answer to that question is no, like that partner is too stressed out or that team member is too stressed out, it could be a nurse at the sending hospital, it could be a paramedic who's part of the ambulance service who initially interacted with the patient. I think the first goal is to get those people back in the game. Getting those people back in the game can be very challenging because they feel, like they've lost this internal locus of control, that the system is spinning out of control faster than they can perhaps process it, and they're like almost like that deer in the headlights kind of look, or you see them like doing the same repetitive action over and over again, but it's not really getting them anywhere. Those are signs that they're in that zone. And to me, you can actually win those people back. Those people you can get on board and back with the team by giving them simple tasks. So if you ask them to just grab you a liter of crystalloid fluid, or hey, see in that box right there, the blood is in there, can you grab the blood and give it to me? Simple tasks, when they complete them and like you compliment them on that, it can actually get them back in the game a little bit, because they think that there's this cognitive momentum actually that they complete a task successfully, that they have control over at least some aspect of their environment, and they, believe it or not, they begin to come back to you. The reciprocity, the concept of reciprocity, when you do something for somebody, like compliment them, they actually want to, it's not only reciprocity, but it's likability. When you compliment them and they feel like you are on board and they start to like you more, they're more willing to work with you. The concept of reciprocity, if you do something for them, help them out with something, they're more likely to help you out too. So employing a lot of those concepts, as well as sort of giving them simple tasks and getting them back. So it's how you treat them, but then also the things you do to get them back sort of with you. Once you do, I believe now you're sort of on a better track to achieving that goal. In terms of getting the rest of the team bought in, I will stop at various points. Even if I have a pretty good idea of what's going on, I'll say it. I'll say, I think this is what's going on. So-and-so, do you agree with me? Do you think we're missing anything, or there's anything else we can do? If there are particular critical interventions that need to get done, I'll double check with them. I think that also, that mutual cross-checking is a way to get the team very engaged in what's going on. They have to pay attention. They start to realize that you're going to ask them questions, and that they're asking if they think it's okay. And in doing so, that mutual cross-checking actually really makes people pay attention and get involved. You can do that using various tools, so like airway checklists and the things of those nature. I don't necessarily think we can checklist everything to death, but when we use those particular tools, those execute the same sort of processes in terms of the team-based resuscitation. Is they get everybody involved, they get buy-in from everyone on board. So there's probably a long list of things, and I can go on and on, but I do want to be respectful of your time. So hopefully that's at least the start. Make sure that they're on board and they can receive the information, and then begin to do things that not only they can process, but get them more involved actively in the situation and help you out.
Perfect. Great response. Thank you. And maybe just the last question, and we don't have to take it too far, but what was your response with regards to COVID in the US, and how were the pre-hospital and retrieval services involved with that?
So our role is very active. So we're working in both the emergency department and the ICU. the response to coronavirus, actually in our state, was better. The governor of our state actually has a master's in public health and was very progressive in the way things were addressed. Sadly, that was good, and particularly because sadly in various areas of our state, the Native American reservation was hit the hardest. So they're probably one of the groups that we transport the most, and they were hit very, very hard in terms of coronavirus, especially in the initial surge. We were transporting, it's essentially running a shuttle bus, like an air medical shuttle bus, out to the reservation almost 24 hours a day for that first surge in mid 2020. We noticed that after that surge, there was the other one that hit the United States in November to January. And once again, our role was very active. We were constantly transporting patients, in this case, actually, from southern New Mexico and Texas, all over the place. And once again, it was a nonstop come home decon, and there's two or three jobs waiting for you right out the bat, rotor or fixed wing. And that was very, very challenging. I think our teams pulled through, and then when I wasn't there, I was still a registrar, so I ended up canceling, or I shouldn't say I ended up canceling, several of my electives were canceled, and I basically spent long strings of nights in the COVID ICU, which was a good learning experience, but again, pretty awful under certain situations, especially with the ICUs exploding, patients doubled up in rooms. We converted our pediatric ORs and our pediatric post-anesthesia care unit into COVID ICUs on top of the ICUs that were already overflowing with COVID patients. So a lot. I think that it was in a large degree the response of our teams, especially the nurses and paramedics that stepped up, that did really well and helped us get through. They were by far and away the ones who bore the brunt of the battle. I think a lot of it came down to working with our ICU colleagues and trying to stay up to date with the data that was coming out as best as we could. I think when we began to develop sort of more standardized approaches, they perhaps were not. I don't think we still have great evidence in terms of what works really well besides getting vaccinated and good supportive care. But when we came up with general guidelines and established a model and clinical practice guideline for escalating oxygenation therapies and what to do if people were prone and needed to be transported, and a lot of these things they hadn't done before. Once we did that, I think we started to hit our stride, and people started doing a much better job trying to take care of these super sick patients. So it was quite an experience. Hopefully be once in a career kind of experience. But when it comes to emergency and critical care, and especially retrieval, it was quite the education.
Cool. Thank you very much. And yeah, it's nice to hear that the situation has been similar around the world. Thank you very much.
Yeah.
That's been an awesome talk. Lots to think about there. And thank you very much for taking time. It must be nearly your bedtime there. But thank you very much.
Oh yeah, no problem. I mean, as a fellow, I'd never sleep anyway, so whatever. But
more caffeine, always good.
I'll have to catch up with you guys sometime soon, because I'd be very interested to hear from your perspective in New South Wales, how things would be going in some of the retrieval jobs you all have been out on for COVID, and what's been working, what hasn't. So,
well, I'm sure that can be arranged. Thank you.
Cheers. Enjoy the rest of the day, guys.
Will do. Cheers. Bye, Mike.
Bye-bye.